is everyone? This is the Troopers 4:15 on a Tuesday afternoon. It's great to have you guys here. So welcome to the Driving Disruption in Medical Education Forum. My name is Josh Golomb. I'm CEO of Hazel Health. And we're excited to have, we have an amazing panel. We're going to try to have some spirited discussion about what everyone here is doing. And just as background, so I've had the privilege of running 3 different healthcare services companies. So this topic is near and dear to my heart. I've worked with pharmacists, pharmacy technicians, physicians. And so for Hazel, what we essentially do is we build virtual health clinics at school sites. So we have doctors basically available on demand for kids at school when they aren't feeling well. And so what I'm going to ask, our hope is that this will be a really spirited discussion amongst these great panelists. And so guys, what I'll do is start and just ask you each to introduce yourself, just a 20-second introduction of what you do and kind of the biggest disruption that you think about in your world today.
Hello, my name's Alvin Bisarya. I'm Vice President of Healthcare Innovation at Kaplan, and I run our allied health business and our virtual simulation business for physicians and nurses. Biggest disruption, we think, from our perspective, is that the acceleration of competency development in medical school and nursing school and on into residency and training, and increasing access to those accelerated pathways. So how do you make it economically feasible and technologically accessible to those accelerated pathways to competency development?
Great. Hey everyone, my name is Shiv. I'm the co-founder and CEO of Osmosis, which is a health education platform that I started when I was in medical school at Johns Hopkins. And we recruited the team that used to run Khan Academy Health and Medicine, and now have about 1 million YouTube subscribers. And the biggest disruption I see is kind of the role the patients are going to be playing. I mean, all of us are consumers of healthcare or take care of others who have to consume healthcare. So whether you're either a clinician or trying to be a clinician, or you're a caregiver, I think patient education is going to be one of the major disruptive things in the next decade.
I'm Brian Kelly. I'm the president of clinical health at Ascend Learning. Been in healthcare for 25 years. We believe that one of the biggest opportunities in healthcare is to remove variance, which is the largest source of waste and the largest source of poor outcomes in the entire system. One patient goes to see 2 docs in each of 50 states. They get 32 different treatment pathways, of which only 2 are correct. The other 30 that are wrong are a result of lack of competency, lack of training, lack of clinically specific continuing education.
This is Dr. Chandra Pemmasani. I'm the founder and CEO of UWorld. More than 90% of graduating physicians and 80% of nursing students use our products to prepare for their high-stakes exam. And the biggest disruption we did was actually on a couple things. One, we disrupted the medical textbook business. The second, expensive review courses that medical students and nurses do, we disrupted that business with a highly effective, cost-effective solution that improves learning outcomes significantly.
Great. Well, welcome guys. So first question for the group here. So a lot of hot topic is machine learning, artificial intelligence. A lot of discussion like what will it look like for, let's just talk doctors first. So what do you think? Do we have a need for doctors in 10 years? What's AI going to do to the medical profession from your perspective? And by the way, I think we have 2 medical school graduates, 1 medical school in process, correct? And so we've got some folks who've got it. So Andy, would love to hear your perspective.
Yeah, I'll go for that. I mean, artificial intelligence will have its own role in every specialty that you think. But I think in medical field, it will have less impact compared to the rest of them. For example, in medicine, if you take radiology, it's something that's easily replaceable by artificial intelligence. 70 to 80% of the radiology images that physicians request comes back as negative. So if AI can identify what is normal, that's right there. You can eliminate 80% of the radiologists. It's the same thing with pathology. You can do quite a bit of artificial intelligence. But when it comes to primary care or family practice, those are extremely hard to replace with artificial intelligence because the major center of the whole thing is physician and patient interaction. So I don't believe the physician jobs or anybody will be replaced with artificial intelligence anytime soon for the large part of medicine.
Okay.
So I'll jump in there. I think, talking about 3 levels of AI, and Chandra mentioned one, which was categorization or pattern recognition, which you can think of with radiology or pathology. The next step that we're talking about is diagnostic decision making. And I think the real barrier there, which I agree, it hasn't really gotten there yet, but is really access to the data. And we look at what's happening in China right now, and I think we just saw an example in Guangzhou where they looked at, I think, 1.1 million patient records across a broad variety of disciplines, but pediatrics mostly, and they were able to get a minimum of 80% diagnostic accuracy there, and 86% similarity to junior physicians, and pretty close with the senior physicians as well. And you look at China versus what the main barrier to that happening here, and I think it's the restriction and our cultural and legal system that has a different answer to that patient-physician privacy issue. So I think when you think about AI, it's really teaching the machine versus machine learning, which is supposed to teach us something. And so if I had to say where the greatest opportunity is if we can, just like we're trying to do with oncology at MD Anderson and other places, where we can have the algorithms learn on their own and teach us something, I think that's the biggest frontier that you have right there.
Got it. Okay.
But even in oncology, IBM Watson tried significantly, but they were not able to be successful.
At Optum, I ran the clinical analytics business, big believer in big data, and I'll disagree slightly with Chandra in that doctors won't be replaced by AI. Doctors will be replaced by doctors with AI. And in fact, primary care is the exact place where AI plays, because the interactions are seen to be limited only between the patient and the provider, and don't take in all the other information and patterns around that person's life, which to a very large extent controls progression of disease. Being able to bring that data in, pattern recognize it, and put it in the hands of the primary care physician who otherwise can't elucidate it through discussion is going to change the way they practice, I think.
Still, the doctor will be there.
Oh yeah,
That's the whole point.
So doctors
So it will
won't
be
replaced by
augmented.
AI. Yes,
Exactly.
all doctors will be augmented by AI.
Exactly.
Yeah.
Yeah, I agree with that.
So augmented is your.
Yeah, it's augmented,
think
not
so.
replaced.
Absolutely.
Yeah. Well, so then let's talk. So how does that play out, though? So if you think about medical school, so I work with a lot of primary care doctors, have no training whatsoever in what you're describing. So how does medical school need to train to get physicians ready to be able to do this kind of work?
So I'll jump in there.
Yeah.
So I think medical school has had this thing called the Flexionarian model for about 100 years. So Flexioner wrote a report in the early 1900s about the prototypical medical school, which when he was writing it was Johns Hopkins School of Medicine, which was 2 years of preclinical education, basic science type stuff, followed by 2 years of clinical education, which is the rotations that many of the people who've become doctors have had to go through. Or you spend like 2 months in OBGYN and 2 months in neurology. And so I think what we're finding at a lot of medical schools that we work with is they're very interested in how do we train the future clinicians, not just for the job that they have to do in the clinic when they're on the wards in 2 years, but what's going to look like in 5 or 10 years. So they're trying to make students lifelong learners so they're more capable of picking up new skills along the way. One issue with medical education right now is it's super siloed, right? You have to take pre-medical courses, then medical school, then residency, then continuing medical education, and these silos don't talk to each other. I think what we're finding in the health professions is they're trying to break down those silos so that a first-year medical student or a third-year resident are all being introduced to some of the same soft skill topics, and we're able to portfolio them and understand what they know and what they don't know so that we can remediate them along the way. And I also think there are a lot of third-party companies and resources, some of which are on the panel, that are trying to fill in those gaps that current medical schools have left out and don't have the potential to do that training for.
Anything you guys would add?
Yeah. Maybe what we discussed, we had a pre-meeting. In this world of artificial intelligence augmenting the doctor, artificial intelligence is not going to give an answer. It's going to give an odds table. And one of the things that we think needs to change within the educational process is teaching doctors that it's a decision under uncertainty. The answer is actually not knowable. And being comfortable with the idea that there's a confidence interval and an odds table, and not search through continued test for an answer that's not knowable. And it's a mindset shift, and we think a training shift.
Okay. Well, go ahead.
I think another change, which we're talking about with med school, and Chandra and I could see if we agree about this, if you put yourself with the hat of a med student on, you're going to see somewhere around 10,000 multiple choice questions in that 4-year time span. You're going to see probably, give or take, 200 patients. And every one of those patients, the diagnosis is already in the chart. You're never actually going to have to solve that medical mystery on your own until you either become a sub-I, which is in your 4th year, and that's anywhere from a month and a half to 3 months, or day 1 of your internship. So I think the real question here is, what is everybody doing in medical school, especially for the first 2 years? And a lot of them are using Chandra and my company's products, instead of showing up to class. But the challenge here is that why are they not seeing patients? Why are they not integrating that knowledge and developing the competency to actually help a person? And that's the real question facing med school, and leads to a lot of different answers.
But the problem is, the basic science people who teach anatomy, physiology, biochemistry don't have clinical experience. At the same time, the people who are teaching the clinical experience forget a lot of the basic sciences. So there is a gap between what is, when they are reading basic sciences, they don't understand how it is clinically reliable or relevant. And when they go to the clinical sciences, they forgot these basic sciences. They can't understand the underlying core pathophysiology. I think the medical schools have adopted to combine or get the clinical information very quickly into the basic sciences. Not every school has changed that curriculum, but some are doing it. But that's where products like UWorld or Kaplan and other people will do a job. We try to bring a lot of clinical people, let them read the basic sciences and integrate, so the students will find it a lot more valuable when they're reading the basic sciences, because they know how it is relevant in terms of patient. When you say 10,000 questions, you consider them as 10,000 questions. Yes, they may not mean anything, but if you see them as 10,000 patient scenarios where you need to apply both basic sciences and clinical context, then it's actually quite powerful. Even if you can go through 5 or 6 years of medical school, you may not be able to see more than 400, 500 patients. So how can you accelerate that entire process? Even if you go to the best schools like Harvard and Hopkins, you don't see all the rare conditions or rare presentation of the diseases. And that's when the software or platforms like UWorld or anything can add immense value.
Yeah. Well, that's good. So we talked a little about the sort of analytical side of the medical profession. Let's talk about some of the soft skills. I think you were touching on the Shiv. But so there's a big push towards kind of consumer-driven healthcare. There's concierge care, there's direct primary care, people getting access to doctors at their workplace, at the school like we do. So how do you think about what needs to come into education to have folks adapt to a world where they're being now held accountable to a set of sort of consumer standards that maybe didn't exist before? Any takers?
I can jump in. So I think, Brian and I were talking about this. I think there's a lot of, so health education is different than other forms of education that ASU GSV typically highlights for 3 reasons. One is it's vast, right? So there's whole fields that have been discovered since you guys were in med school, not to date you, but it's only been a couple of years since you were in med school. There were things I was learning about in med school that probably weren't even taught at Northwestern when you were in med school. So it's vast, it's dynamic. So there's a stat out there that 50% of what you learn in med school is out of date within 5 years of graduating. And then it's high stakes, right? You forget how to conjugate a verb in Spanish, you're going to embarrass yourself, but you forget to provide a pulmonary function test to somebody who's taking bleomycin, you're going to hurt that patient. And so for those 3 reasons, I think the stakes are much higher, but you can also measure outcomes where, say we deploy a continuing medical education activity at one hospital or to one half of one hospital versus another hospital. Does it have a measurable outcome metric? Will people who have diabetes have less amputations? Will people who have upper respiratory infections that are related to viral consequences get fewer antibiotic prescriptions? And so I think there's an opportunity for health education to basically prove its value through healthcare cost outcomes and quality outcomes. And so I think part of that equation is not just making clinicians better, like many of our companies are trying to do, but also making patients more engaged in their health. Because to prevent amputations in a diabetic, one thing is making PAs and nurses and physicians aware of to screen for ulcers and other problems. But the other problem is to make the patient aware of this fact and to educate them. So I think approaching it from both angles and then measuring those outcomes in a really cost-conscious and quality-conscious way is where the field is headed.
There's an excellent body of work out there that shows to the greater extent a patient is engaged in understanding their disease and to the greater extent that they're confident in navigating the health system will be the greater outcomes. Body of work can point out afterwards. But what that leads to is the opportunity with patients to train them actually on the mechanics of the health system. It is daunting, even for those who work in the health system, to get through an entire course of treatment from heart failure to any one of the cancers that are out there. And so making them aware is a huge job and a huge need and opportunity about their disease and its progression, but also making them confident of how to navigate through, what discussions to have, what type of information they should seek, and what role they should play is really important. And fundamentally, it's a patient education issue.
But I'm curious from your perspective. So now, like, we see a lot of settings where, whether it's doctors or nurses, they now get NPS scores. So clinics will get Net Promoter Scores, that are actually evaluated on whether or not people would refer other folks there, which is sort of like a retail setting. And what's your view on that as both physicians and leaders in education? Like, is this a good thing? How do you think it changes how physicians and practitioners need to think about how they engage?
I think NPS score is extremely important, right? I mean, if you have more than 50, you really have a successful business. So I think just like any other business, I think healthcare should have those kind of metrics, especially NPS kind of thing.
So to push back on that, I mean, so if you ask a lot of doctors really don't like patient satisfaction scores, because especially psychiatrists, because you're dealing with a population that sometimes you want to prescribe them something that makes them feel worse in the short term, better in the long term, or you say you can't get this medicine, especially in pain clinics. Your NPS score or your patient stat scores are going to be pretty low, but you're providing good quality care. I will say, so one article that was pretty influential to me and our team a couple months ago was in the journal of JAMA, Internal Medicine, and it showed that the number one predictor of patient satisfaction scores among physicians on telemedicine, among patients who presented with upper respiratory infections, is whether that patient left with a prescription for an antibiotic, regardless of cause. So if the patient had a viral infection or bacterial infection, they still wanted an antibiotic, and if they didn't get an antibiotic, you get a lower physician score. And that's not good. That isn't high-value medicine. And so that's where I think, again, what we were just talking about with consumer-driven healthcare, we're entering a market where it's not just seller beware anymore, it's buyer beware. Have you guys heard of like Hims or Roman or these I mean, there was a New York Times article about this last week, where you can just go on and get a 10-minute telemedicine consultation and get a prescription for propranolol or something, right? And so while that probably is a positive thing for most people who take those, without the proper education, there's going to be a lot of consumers who have terrible side effects or are very unhappy with those decisions without the proper education. So I think it's important to not just go with patient stat to measure patient satisfaction, but have it as one of like a holistic picture of how that clinician's performing or that health system's performing.
But there is always an exception every time you try to do something, right? There are 10-20% of the people that are unhappy when you talk about pain medicine doctors or whatever those things. But rest of the large organizational perspective, I think NPS scores do create value. Initially, it creates some stress to providing good quality care, but I think in the long run, those things will make even physicians a lot more accountable. And I have seen, in my experience, a lot of physicians that don't keep up to date with the medical knowledge. They don't take care of the patients the way they should be taking. I think once you start having these kind of reviews, I think everybody would be a lot more accountable.
I guess what you'd have to believe for that to be true is that NPS or patient feedback leads to better outcomes. I mean, that would be the assumption there, and I think there's a whole set of confounders there, right? So, and Shiv brought up one, not that NPS or HCAHPS, which is far more prevalent, is not a ingredient, but take the question of investment. So there's a legendary HCAHPS story. This is the hospital score that takes in patient experience, but also 12 other measures into account as well. I believe it's at Cornell, but we'll have to Google that and check on it. But the HCAHPS scores for one floor in Columbia Cornell Hospital shot up over a 3-month period. And this is longitudinally measured every 3 months or so. And they went and investigated and said, well, gosh, like we need to replicate everything that those physicians and nurses are doing. Great study, like all of us would do, deductive reasoning and so forth. And they couldn't find anything that was happening that was materially different on that floor than the other internal medicine floors, except for one thing. The elevator service had improved because the elevator was broken, and the carpets had been redone. Now, it's really difficult to work backwards from that and say, well, okay, so elevator maintenance leads to better outcomes. I don't think anybody would believe that correlation, but the investment decisions that come from something like that are very real, right? So what would you say if you were a hospital CEO? Okay, so let's invest in perhaps more continuing education for physicians, or maybe we should get a facelift for the entire hospital because it's going to connect to HCAHPS scores, which is going to get me better negotiation with insurers and better reimbursement. And I think that just the question is, just like we would do if we were physician scientists looking at anything else, is there a logical chain between the measure and the intervention? And I'm not sure it's always there, not that I don't think it's valuable, because if we look 30 years ago, nobody was asking these questions at all. And we had 60 years ago, not to date myself, but the paternalistic model of medicine would say, hey, NPS isn't important at all. So NPS is important, but I mean, let's double check what's really driving the decision or the outcome from that.
So you see association, but within reason. Okay. Well, so we've talked a little about this, but I want to chat about quality. So just sort of audience fun fact participation. So anyone want to guess how much did the U.S. spend on healthcare last 2018? Anyone want to know that number? Throw out a guess. $3.5 trillion. That is amazing. This is so $3.6 trillion. So 18% of our GDP in the U.S. was spent on healthcare. But as you guys know, unfortunately, if you look at most metrics compared to other developed countries, we look at life expectancy, infant mortality, we typically are near the bottom or at least in the middle. And so how do you think about the role of education? Obviously, there's a lot of things that drive that, but the role particularly of education, so change that equation here domestically. Yeah.
If you de-average that curve and take a look at oncology, the U.S. outperforms every other country in the world in terms of mortality rates. But if you look at the other part of that curve that looks at end-of-life treatments and the sickest of the sickest, we're even worse as compared to the others. And I think what it comes back to is guidelines and standards. And there have been, again, a number of seminal papers talking about the role of hospice as compared to stage 4 cancer treatments, better outcomes, better quality, better system economics, and yet it's poorly adopted. And so spending on the sickest of the sick and spending on end of life, and this is by no means a death panel perspective, this is actually a patient-centered best outcome perspective, is egregious in terms of its inefficiency, and that I think comes back to an educational issue. The system has not adopted, is not aware of the best practices, and that drives a tremendous number of hundreds of billions in spending that creates nothing. It's an educational problem.
Okay.
I mean, the other way you can do is obviously a better way of making a diagnosis, making the clinicians and healthcare providers good at what they do, accurately diagnosing with the least number of tests. I have had physicians, when I was doing residency, somebody comes with stroke who smokes cigarettes, who has diabetes, hypertension, but he gets 30, 40 tests. We know the reason for the stroke. You don't need to test a syphilis in a 70-year-old. Yes, syphilis can cause stroke, but everybody gets all the tests. I mean, that's one way of fixing it. And second, medical records, portability is an issue. People go to different hospitals. When you are in emergency, you will be taken to the nearest hospital, and then you will be discharged. You go and follow up with another hospital. It's very hard to get those data, and physicians all the time repeat everything, and it accelerates the cost of that thing. Those two, and also how we compare the cost of in America versus rest of the countries is also an issue, because most of the innovation happens here. When you are inventing a drug, it costs multi-billion dollars, whereas other countries don't spend that much money. And obviously healthcare is spending that much money to pay off the cost of innovation. So that's included. I don't think that's a good apples to apple comparison in my view. And the fourth thing is, it's actually healthcare cost is the end result of what is happening at the patient level. Patients are obese, not exercising, the behavioral issues are there. If you take the alcohol use, tobacco use, and obesity, I mean, that's 80% of all the diseases. And the burden happening at the healthcare, but it's the symptoms are happening at a different level. So putting entire cost on the healthcare is also not fair in my view.
And so this is one of the positive potential interventions of education. So we have a collaboration with the primary school, which is Priscilla Chan's school, and we have a series of videos we've developed with them on everything from asthma to toxic stress and other things that parents and teachers and eventually the children should learn about. And this is students who are up to 4, 5, 6 years old. And so I think to Chandra's point, if we can implement education that leads to, at least helps with behavior change, or at least from pre-contemplation to contemplation stage, we may be able to kind of shift the population dynamics that are leading to these increased healthcare spending costs. The other thing I will say, so that's a positive potential use of education, and all of us here are at this conference because we believe in the positive aspects of education. One negative aspect of education that you guys see every day on TV is things like direct-to-consumer pharma advertising, and also what they do in terms of CME, the continuing medical education. One particularly influential book I was telling you guys about, I read last year, was Dope Sick, about the various things that contributed to the opioid epidemic we have in the US, which obviously has led to a lot of, not financial costs, but emotional costs and death. And so one of the contributing factors was all the CME being spent by Purdue to make pain a fifth vital sign, and to basically get doctors and others to prescribe much more severe opioids for things that could have been managed non-medically or with less severe pharmacological measures. And so that keeps me up at night, which is we're an education company in healthcare. What is the pharma company that's going to want to pay us a lot of money to then do like an education campaign about pain being a fifth vital sign? And so I think there's a responsibility that we as health education companies and people involved in health education have, more than maybe other forms of education, to pay attention to the negative consequences of education.
Okay, let's switch gears a little bit, because we've been talking more at the physician level. So if you think about by 2024, so I think the Mercer report says there's be 2.3 million new jobs in healthcare. Growth rate of 19%, but most of those aren't physicians. Most of the shortages will happen, there is on primary care physicians, but the majority of those are things like home health aides, lab techs. So a lot of really important jobs, but typically don't pay very high wages. So how do you guys think about kind of closing some of that gap, particularly because this is a large part to support this aging population that we've got here in the US? How do your companies, other folks solve that gap?
There's an opportunity with home health aides and nursing assistants to boost, if you will, enrollment in front of acceptance into a program. We know that those jobs are typically populated by individuals who are just starting a career, no matter where they come from, and English is typically their second language. It's just the demographic of the folks that are in there. But there are many, many, many folks in that demographic who might be just shy of the training and the education necessary to be accepted, even at a community college. And what we've been able to do in our nursing programs and working with clients, as an example, we have intellectual property around the acceptance test, the T's, into nursing school. We're able to assess folks who are just short of the line and remediate them and create a bullpen of individuals who will soon be ready to enter nursing. And the same dynamic we believe is true in the allied health professions and at that base of the pyramid with the healthcare worker, in that there are many more who want to be in those professions but may not be qualified. And so boosting them up and above through the types of tools that all of us here have available is an opportunity to increase the number flowing through the funnel into those professions.
I'll jump in and add to that and build on something that Chandra said. So if you think about the 10,000 MCQs for physicians and 200 patients, this problem is far more challenging for the professions you described in allied health. There's very little clinical opportunity before they get on the job. There's no subsidized residency, which is paid for entirely by Medicare. It doesn't exist for these folks. So if you could create an educational system that simulated the conditions that we're talking about, integrated the knowledge that we're doing, as you said, take it from an MCQ to an actual patient experience. This is a huge opportunity to reduce the cost of education, because in addition to being lower paying jobs, the actual cost of education for some of these folks is the same issue that you find in many other professions. They're often debt-laden, and there's an opportunity to bend that cost curve by using simulation, defining those competencies, getting them the at-bats, if you will, a lot sooner in their short education so that they can get out there and perform and drive patient outcomes a lot more effectively. And I think, our company and others are looking at how you can actually create that simulation in a cost-effective way at scale to make that outcome happen.
That's good. And then you touched on something that I was curious of. There's been so much discussion on student debt across all professions, but obviously it's a huge in the health. How do you guys think? Will technology help make that much more affordable and address that? How do you think that will play out?
Yeah, so going back to the Flexionarian model of education, where students largely are wasting a lot of time and hours and money going to traditional programs. I'll give you a quick example. So my co-founder, Ryan, before we started med school, he got a PhD in neuroscience. And at Hopkins, at the end of our first year, we do a 6-week neuroscience block. Now, Ryan could have taught that course, let alone tested out of it. And so, but he, in a time-based framework of education, had to do the same exact 6 weeks, which costs about $10,000. Roughly the median debt of a graduating physician is $200,000 now. And so if we're able to shave off a lot of these time-based forms of education and let people, as Alvin was saying, test out through competency-based frameworks of education, and also upskill. So that's one thing I would love to see health professions borrowing from coding and software and other things that ASU GSV has highlighted in the past few years, is that I've met a respiratory therapist at Ross University in the Caribbean who had to go through all 4 years of med school again, even though he had 25 years of practice as a respiratory therapist. He could probably have skipped out of at least 50% of med school with all that clinical experience he had. So can we make it possible for people like Ryan or this respiratory therapist to test out of things they already know in a competency-based pathway and then become contributing members to the health professions as soon as possible? And that goes for patients too. I think that's one of the core things, is why do you need a clinician for every one of these things? As more of us have to take care of our aging parents or our children or whatnot, I just see caregivers and patients playing a much bigger role in our healthcare and reducing those costs than needing to go to the priest or the sage on the stage for every single thing that people have.
Exactly. A lot of the stuff, like for example, pharmacology, you really don't need to go to a med school to learn pharmacology. Yeah. Anatomy, yes, you need to go there, you need to dissect, and you need to learn. So you can, at least first 2 years of basic science, you can reduce significantly by using the technology.
And you're seeing med schools do this. And so NYU has now a 3-year medical program. Duke a while back moved the clinical years up. I think that experimentation is taking place. That will help. It's interesting why hasn't it happened already, right? Because if you look at the information that's in the first 2 years of medical school or the first year of nursing school, it's completely commoditized. I mean, you can actually access all of it for free right now, not in a structured manner, but if an enterprising young individual could get to it. So why hasn't the cost curve changed? And I think there's several reasons, and one of them is that you talk about the Flexionarian model, we haven't really disrupted at scale because of fear. There's a fear that if you don't put people through the time-based piece, then there's a liability on the other end. And I think this comes all the way back to what is the competency that you're looking for? And I'll use a fanciful analogy here. I mean, if this was a sport, if this was basketball, the NBA, baseball, choose your sport, you can see that. You can see competency. You can see that, why is a LeBron able to jump to the NBA? You can see it. It's obvious. Like anybody can see that. We have not, I think, as an industry, kind of delineated this in a specific enough manner to have the confidence that, okay, patient outcomes are going to be as sure as LeBron being able to score 30 points a night. We don't have that analogy yet, so you start to work from a place of defensiveness, and you put people through this long system. So, I think it hits variability too. Where is that variability coming from? Partially a lack of definition. So I think once you see that and you're able to see what the outcome is that you really want, I think people are not going to put up with the the cost of education being that much, because then the path will be clear.
And it's also hard to create medical schools that are disruptive. You just can't go and build a medical school that easily. So people have to follow whatever the systems have been built. So it's hard to disrupt that kind of stuff. It's a regulatory limited number of people. It's highly competitive.
Yeah, and Chandra and Alvin, particularly for the two of you, because your organizations invest a lot in education, in like testing and improvement. Like, have you been able to see over the last 10 years that driving improvements in scores and any correlation between that and actual performance post-graduation?
But I can tell, we started in 2003. At that time, the licensing exam, there is a standard deviation and the passing score. Standard deviation was 175 to 280, and the mean was 210. I mean, after we started, today the mean is 240 and the pass is 200. So the mean and median shifted completely to the right side.
Yeah.
So there is a significant increase in the test scores. But do I have an objective finding, but did it change the medical outcomes? I hope so, but I don't have the objective evidence to tell you that it did.
Yeah.
Yeah, what we see, and again, to piggyback off of Brian, is that there is only partial correlation between MCAT and USMLE to residency in terms of actual outcomes that you see there, and from residency and board scores to competency as an attending physician. There's only partial correlation across every one of those steps. And the reason why these scores become so important, as we all know, and anybody who's been involved in physician training, is that those step 1 scores determine your whole life. Residency directors decide on that, and there's a reason they decide on that, because it correlates really well to their board scores that they take as specialty physicians. The proof would be in the pudding of patient outcomes, as you said, and we can't see it. We don't see that. I don't think the research is there, to my knowledge, that there's any proof, which doesn't mean that it isn't a wise investment. But again, it kind of comes back to, well, maybe there's a lack of understanding of what it is that we're really aiming for here, and maybe the mechanism to get people to that place is not really well defined. It's the somewhat of the street light and keys effect, if you've heard that story, that looking for your keys in the light of a street lamp, because that's the only place it's lit. So if you can't see what you're trying to go for, then maybe you're not going to build a set of exams that are actually going to get to a better place for physicians or nurses, for that matter.
The other reason is, I could be the greatest clinician, but when I'm seeing a patient, I don't want to miss something because this might end up in a lawsuit or something. So even if I'm a great physician, that may not change the outcome because of all the regulatory issues and other fear of missing out kind of things.
I guess we have about 2 minutes left, so maybe one last question I think that I'd ask each of you. So when you look out 10 years, what are you most excited about? Like, what disruptive change do you think will happen that you're personally the most excited about? Anyone can start.
I can start. I think the medical schools, nursing schools, and the programs will adapt into a situation what the students want and patients need rather than the other way around.
I think that the role of all the stakeholders in medical education as they get out to, to practice will be, they are not artists, but rather systems integrators and systems engineers.
I think, so I've mentioned this a couple times, but I think consumer and patient education is going to be one of the biggest shifts. We're going to need 50 million more healthcare professionals over the next decade to keep up with demand, according to McKinsey. But I think the only way to actually accomplish that is if the patients play an active role in their own education and engagement as well. So I think we'll see a lot more disruption and innovation in that space.
I'm most excited and hopeful for the science of empathy to play a role in all this, and we've talked a lot about the technology, the economy, diagnosis, and so forth. Empathy makes a difference. There's data to show that. If you can connect with the patient, it can have an effect as strong as any placebo. The science has not figured out how to actually reverse engineer that and how to build that. So that's the missing piece in the equation that I'm hopeful that medical education address in the future.
Well, I'd like to thank the four of you. As someone who works with healthcare practitioners every day and patients, it's like exciting for me to hear how thoughtful you all are about how to take that to the next level. So if you join me in thanking the panel for joining.
Thank you.